We'll go ahead and regroup here to start the next session. And I'm going to ask both Dr. Jain and Dr. Voigt to join me up here for this session on AFib ablation, practice-changing trials, initially by Dr. Sandeep Jain. And then we're going to go on to surgical approaches for AF, and Dr. Voigt is going to be giving that entire talk. So it's a pleasure for me to introduce Dr. Sandeep Jain, who, as you know, is the director of the EP services at UPMC. And he's going to be telling us everything we need to know about AFib ablation, recent trials, and importantly, focusing on how it impacts on our patients and how we refer them and how we treat them. Sandeep.
Great. Thank you, Mark. Thanks, everyone. Appreciate everyone's participation today and look forward to interacting with the virtual team as well that are joining. So, mouse is all right, these are my disclosures. So I wanted to start with a brief case presentation that I think a lot of us see and how we kind of go through it. A 66-year-old with a history of hypertension and symptomatic paroxysmal atrial fibrillation. So going in and out of atrial fibrillation on her own, despite antiarrhythmic therapy with flecainide, and presents to discuss further options in our clinics. She has a CHAS2-VASc score of 3 and is maintained on Eliquis anticoagulation, which would be appropriate according to the guidelines. And the general discussion we all have with all of our patients when we're thinking about atrial fibrillation and how it impacts them is a strategy of rate control, picking a different antiarrhythmic at this stage, or considering ablation. And because this talk is focused on ablation, I just want to go through a little bit of the history of how we got here in terms of atrial fibrillation ablation. So this is the seminal trial that really opened our eyes to the pulmonary veins being the source of much of paroxysmal atrial fibrillation. So what happened in this study that was published in the New England Journal now more than 20 years ago is what you're seeing on the left is some of the data from an EP study done in Bordeaux, where they took patients with paroxysmal atrial fibrillation, so they were going in and out on their own, brought them to the EP lab and said, you know, at some point, this has to be starting somewhere. So they put catheters in multiple positions in the heart and basically waited for those patients to have atrial fibrillation. So as you can imagine, this was in Bordeaux, France, so the rules are a little bit different. And in the control room, these investigators were literally, at least folklore is, sipping wine while they waited for their patients to have atrial fibrillation. And if you look on the right, is where did they find, each dot is where they thought atrial fibrillation started from in these patients. And what you see here is in the left atria, where the pulmonary veins enter the atria, in the pulmonary veins was the bulk of where this came from. And ablation at these sites provided symptomatic relief and freedom from atrial fibrillation in those patients. And that is what spawned what we do today, what we call pulmonary vein isolation, AF ablation, and is the cornerstone of that management. Now, another interesting tidbit is I, at least, was in training when this started, and at least I think for several of us at that time, we thought, what would be more interesting than being able to sip wine in the corner and advance science at the same time? And this is also when I would say the co-chairs, Dr. Saba and Dr. Estes, also changed their minds about device implants and said, you know, I can get into this ablation work as well. So there's a lot that came downstream from that, and I think we still enjoy that, although without the wine, at least in the EP lab. So where is rhythm control today? This is from the AF guidelines and how we think about management for rhythm control. So many of our patients, when we kind of, as you've already heard, structural heart disease, no structural heart disease is a big dichotomy of how we think about these patients. We have multiple antiarrhythmics to offer. What I tell all of my patients in the clinic is whenever you have 4 or 5 medicines to try and do the same thing, it tells you none of them are perfect. And we all know that all of these come with side effects that we have to watch. There are contraindications. And at the end of the day, amiodarone is down here at the bottom, which for most of our patients is not a good long-term strategy because of the long-term toxicity potential. And catheter ablation is an option. And if we look at what are our options for catheter ablation today, there are two dominant ablation techniques that we have. Radiofrequency ablation, where we're by conductive and resistive heating the tissue and causing necrosis, or a cryoablation, where we're actually removing heat from the tissue and still resulting in tissue damage, so that we are isolating electrically those pulmonary veins using these technologies to eliminate any chance of abnormal signals that are originating from there reaching the rest of the heart. And if we look at how these have evolved, this on the top here is a point-by-point approach where you go around a vein and literally lay brick, if you will. And that's the classic way that was shown with radiofrequency energy, and now no longer new, but a decade-old energy of cryoballoon, where what we call a single shot technology. And where did all this start from, and what are the trials that tell us that it's of value to do this? So, and this was really a bit of a paradigm shift trial. I know certainly for us at UPMC, when the STOP AF trial was being performed and the results were published, they took 245 patients with paroxysmal atrial fibrillation who already failed an antiarrhythmic. So I think this was informative to us in terms of, well, what's the success when you take those patients and randomize them to a second antiarrhythmic agent, like one of those that I listed there, versus going to an ablation. And those patients, and the outcome was freedom from atrial fibrillation as with event monitoring, Holter monitors at frequent points. And those patients that received a second antiarrhythmic, only 7% could you maintain sinus rhythm. And those that underwent a cryoballoon ablation with about almost a couple year follow-up, 70% freedom from an atrial tachyarrhythmia at that time. So I think it told us a couple of things. Number one, what our common practice before this study came out was often, because a radiofrequency ablation may be several hours in the lab with this tedious point-by-point approach, we would make them often go through a second or even a third antiarrhythmic drug trial. And, you know, what we learned, even though we didn't necessarily know it from data, was we would always tell patients it might work, it might not. But you can see the second antiarrhythmic drug efficacy here is really abysmal. And I tell most of my patients it's going to be less than 50-50, and that's being optimistic. And it also told us that this strategy of using the balloon, although a small number of patients, may be a viable one. So what happens in a cryoballoon ablation? Similar to what you saw with left atrial appendage, this is a femoral venous procedure, a transeptal puncture with a wire that's placed in the pulmonary vein, which you're seeing here, and a balloon that's inflated, and then contrast is injected to show that we have occlusion of the balloon, and that's really the key. If you have occlusion, all surfaces of that balloon are touching the pulmonary vein, and you have apposition, where then we turn on cryoenergy and freeze that tissue. So the next natural question that came up, and there was years of debate amongst electrophysiologists of, well, what strategy should we be using? Should we be using our tried and true radiofrequency energy? Those that have been doing that for years would say this is the best way to do it. I do it well, and so should everyone. But what we also knew was this cryoballoon was new kid on the block. And sure enough, this Fire and Ice trial came out. It was performed and published in the New England Journal of Medicine, multiple centers where patients were randomized who had paroxysmal atrial fibrillation, failed a drug, randomized to cryoballoon ablation versus radiofrequency energy. And it's amazing. I don't think you could have made up these curves to be any closer. So really showed equivalence in efficacy of maintaining sinus rhythm. I will point out, though, where are we here? This is 35, 36% recurrence rate at a year. So it's not perfect, right? It helps us maintain sinus rhythm, but that's still leaving a third of our patients having AF once we're done. After this trial came out, then the real question I think we all ask ourselves when it comes to a procedural technique, well, can we generalize this? Can this be done in your local institution? Can it be done the way that the trials show, which are highly selected centers that have experience? So, and mandated, I think, to the credit of the FDA of any new technology around the time coming here and after this time was, well, what is happening in the real world? What is the post-approval data that happens with these type of studies? And we were lucky enough to be a part of this study that came out right after the approval of Cryoballoon at multiple centers, 39 centers, 344 patients, to look at, well, what is the freedom from atrial fibrillation over a couple of years? And it really fell in line. 1 year freedom from all atrial tachyarrhythmias over 80%, 75% at 2 years. I think with a reasonable, and we can discuss this, I think very important, what's the complication rate? I think two things that came out of Fire and Ice that I didn't mention: procedure times were shorter in the cryoballoon group, readmissions were less in the cryoballoon group, and reablation numbers were less in the cryoballoon group. So that it really, I think, generated a lot of excitement to say this single shot technology may be of value. But I think as you lower the bar to start thinking about applying therapies like this, you need to look at, well, what's the complication? What's the safety profile? And in Stop AF at multiple centers, about 5%. And here's what they were. A biggest thing that we worry about is phrenic nerve injury, because the phrenic nerve runs along the right-sided pulmonary veins, especially the right superior pulmonary vein, and isolation of the cryoballoon of a pulmonary vein with cryoballoon can result in phrenic nerve injury. There are multiple methods now to mitigate this. And when we looked at our own data, which I think is important wherever anyone's practicing, is local expertise has to be driving, just like we talk about whether somebody uses TEE or ICE, has to be driving what we do. These were the first 450 patients we did at UPMC with the cryoballoon soon, right after it was FDA approved. And our overall major complication rate was 2.2%. And even though we may have seen a 10% transient phrenic nerve injury, only 1% of those patients had long-lasting phrenic nerve injury. And again, this included our learning curve of learning how to do this procedure with an older generation balloon, et cetera, et cetera. So I think we have a reasonable data to say it's a safe procedure. We know that about 70, 80%, depending on how you look at it, maintain sinus rhythm at a year or two in a paroxysmal population. But why are we really bringing a patient to the table for an ablation? I think we all know that it's for symptoms and quality of life. It is mostly what is driving a patient who has otherwise a structurally normal heart. And when we looked at the quality of life improvement post-cryoballoon ablation in that multi-center study, in the post-approval study, with a questionnaire that patients got repeatedly at 6 months, baseline, 12 months, and 2 and 3 years, with this SF-12 score that has a physical and mental health component, there was sustained improvement of about 4 or 5 points in each of those in quality of life from after undergoing a cryoballoon ablation. This held true, actually, which I think is even more interesting, in those that recurred as well as those that didn't recur. So what does that tell us? I think what it tells us is we know a third of these patients will recur, but what we are not so up on managing or monitoring is burden of atrial fibrillation. And 90% of these patients feel better after they get their procedure, regardless of this 30-second definition of a recurrence of atrial fibrillation. So that if I take somebody who was having an episode every other day, and now they're having it every 3 or 4 months, that lasts a brief amount of time, in my mind, that's a clinical success and a reason to go through it, as opposed to, you know, what we see if we use that as a strict definition of elimination of AFib. The other thing that I find interesting is, you know, we see a large variation in what causes a patient to have to come to us for atrial fibrillation and the type of symptoms they have. And if you look at after ablation in this group, we had a 60% freedom from any symptom afterwards that maintained over 3 years versus 5% of those patients when they came to us for an ablation. And baseline dyspnea and fatigue and palpitations predicted that. But I think the more important thing is that of those 14 factors, no one factor contributed more than the other in terms of benefit in quality of life improvement, telling me that this is a broad effect of all comers in patients with atrial fibrillation. So I'm going to move on to what else have we learned in terms of big trials for atrial fibrillation. As we start to lower this bar and say, well, we have improvement in maintenance of sinus rhythm, we have quality of life improvement, but can we get some hard endpoints? And CABANA was a trial to try and attempt to answer this question. So a couple thousand patients, the largest really AF ablation trial performed in patients, all comers with atrial fibrillation, randomized to drug therapy versus catheter ablation for atrial fibrillation. And the endpoint was the primary endpoint, combined endpoint of mortality, disabling stroke, severe bleed, and cardiac arrest. Secondary endpoint of, again, combined of mortality, death, or cardiovascular hospitalization. And if you look at the result, and I will mention a couple of things about this. We were a part of this trial. We couldn't find anybody to enroll, in part because when patients were coming to us, they were coming to us with a mission. And it highlights the difficulty in enrolling in a trial when you're randomizing to a procedure versus not. Patients usually know what they want, and it's hard to leave it to a flip of a coin to say you were going to get a procedure or you aren't, or you're going to get drug therapy. And that's why it took many years to enroll in this trial. In the intention to treat group, like we saw with AFFIRM, drug therapy with catheter versus catheter ablation showed no difference. The primary outcome and endpoint was of no difference. If you took it a little different way, again, per protocol or on treatment, again, hypothesis generating, but not concluding. And it showed an improvement in the catheter ablation arm. Now, why is that? 30% of those patients, 27% of the patients randomized to the drug therapy arm crossed over. Going back to the point of if a patient's having debilitating symptoms, they at some point will come to you and with their provider decide that they want an ablation. And that's what happened in this study. If we look at this secondary endpoint of mortality or cardiovascular hospitalization, there was an improvement seen by catheter ablation. And again, all-cause mortality, no change. I think, if we look at what did CABANA treat us, that's a whole other hour, teach us, that's a whole other hour of where we are. But we do know that the catheter ablation group had less recurrent atrial fibrillation than drug therapy, which is in line with what we thought from the other studies. And but at the same time, I think it's very clear that we cannot go to a patient to say the reason you should go have an ablation today in isolation is because of a mortality benefit. I would argue that we were never saying that before CABANA, and we're not saying it today. The reason to do it is this 50% reduction in atrial fibrillation and the symptoms that come with that. It's important, again, as we discussed the significant crossover in these groups, and the on-treatment analysis did show a benefit. So what do we do with that information? And I think the next kind of modern era AFFIRM trial, if you will, in a different way, was early rhythm control therapy in patients with atrial fibrillation with the EAST AFNet4 trial. So this study took patients with early atrial fibrillation diagnosed in less than 1 year to rhythm control versus usual care with outcomes, again, hard outcomes, cardiovascular death, heart failure, or ACS hospitalization, 2,700 patients. And again, this is not an ablation trial. This is a strategy of treatment for rhythm control. Although you'll look at this, how they were divided up in the rhythm control group, about 20% of those patients did end up getting ablation. I think the important thing here is with a median 5-year follow-up, this is not a 1 or 2 year study, this is 5 years down the road, did show an improvement in early rhythm control with these hard endpoints with about equal safety outcomes. There's, again, a lot of discussion behind this. If we look at the components of that primary outcome, death from cardiovascular causes and stroke also met those endpoint, individually met significance. And I think if we take this, it has changed our framework of how we approach a patient. Certainly, as mentioned before, in the heart failure group, for example, how we approach those patients to discuss with them, considering rhythm control early if they're diagnosed early. And a significant portion of these patients, I think, important to note that they were asymptomatic with atrial fibrillation, that we historically would often say, if you're rate controlled and your heart is okay, we'll leave that be, which I think has changed the paradigm a little bit. Also, what's important to note is that in the rate control arm, a significant portion of these patients were actually in sinus rhythm at the end of the study, and we didn't do a very good job of maintaining sinus rhythm in the rhythm control arm. So again, a strategy, not an outcome. So which are the patients I think of going for rhythm control? First time diagnosis of atrial fibrillation, CHF modulated by AF, as we heard about, symptomatic despite rate control, a young patient potentially to avoid long-term remodeling, and if there's no reversible causes. Older patients with comorbid conditions and no symptoms, recurrent AF, failed prior ablation, and significant structural heart disease, you may lean a little towards rate control, in part because we don't have the perfect way of fixing this. So I want to conclude about trials, at least, before I get to a couple of other things. As we see things are getting, we think, safer, as we see rhythm control earlier in the strategy of thinking about managing AF with hard output, with hard outcomes of benefit, the next natural question is, well, should I just be doing an ablation before this antiarrhythmic like all the other trials were performed? And there are two trials published in the New England Journal last year that I think really opened this question up for debate. The Stop AF First trial, again, looked at Cryoballoon as a first-line therapy. These were patients who did not have antiarrhythmics before, 200 patients with the endpoint of freedom from atrial arrhythmia. Showed a benefit in the ablation group versus drug therapy. 34% in the drug therapy arm actually crossed over and ended up having ablation because of failure of drug therapy. And there was maintenance of sinus rhythm in 75% of patients in Stop AF. Another similar trial that I won't go into the details, but early AF performed primarily in Europe and Canada showed a similar result. You will see a little lower success rate, and this trial was unique in that they all had implantable monitors. So we also know that the longer and the better we look for AF, we're going to find it. Still a difference and improvement compared to antiarrhythmic drug therapy. So I want to end the trials real quick with saying, the Arrest AF trial that took patients, when it comes to lifestyle and modification, hone in that we do not do this well enough. Took patients after ablation and said, you know what, we have a program where we're going to watch your diet and intensively put you through an exercise regimen with risk factor modification and watch your diabetes and hypertension versus control. We're just going to tell you to do those things, but we're not going to kind of mandate it and watch you closely. And look at the difference. This is after an AF ablation of maintenance of sinus rhythm. Almost 90% in the group that had risk factor modification versus 48% of those in control. So I think it just highlights where are we going from here, and we need to keep reminding our patients of really working on the risk factors. So where do we go from here from a technology standpoint? I'm going to blow through just a couple of technologies that are out there. There's laser balloon. It has maybe the advantage of direct visualization, but collateral damage. I personally don't think this is going to be the mainstay. We've been a part of this trial with the Heliostar balloon, a balloon like Cryoballoon, but now that can deliver RF. You can change how you deliver it in different locations, and it may have an advantage. This trial is close to enrollment, is in follow-up, and the results should be coming out soon. I do want to highlight what I think is a lot of us have a lot of excitement about being a potential game changer, which is pulse field ablation. And what is pulse field ablation? This is electroporation. So a sub-second electrical field applied across the tissue that opens up the pores and allows extracellular material to come in and result in cell death. The advantage is that it may have, or it does have, specificity for myocardial tissue. So that what we're really looking at is efficacy. Can we destroy these abnormal or these areas to isolate the pulmonary veins, like radiofrequency and cryoballoon do, but collateral damage is what we're plagued with those thermal energies. And in pulse field ablation, at least what we know so far, we can potentially do this without the collateral damage. So that enhancing safety, enhancing efficacy would be sort of the holy grail if we could do it for AF ablation. And these are just some pictures of what it's shown. Preliminary data is great, but again, small number of patients. Those multi-center trials are coming. We were a part of one of them, the Pulsed AF trial, 400 patients also closed and enrollment and in follow-up. So we should have answers soon, another technology as well. Just so it doesn't sound like everything is rosy, I want to tell you about catheters that maybe didn't make it to prime time. We were a part of this first in-man study, only 4 centers, and apparently the other 90 made the right choice not to participate. The Arctic line linear catheter ablation, the thought was cryoballoon seems safe. Let's ablate in that area and see it. It was bulky. It provided some nice results, but didn't make it to prime time by decision of the manufacturer. So what are the unresolved issues? Long-term efficacy and safety. We still need to figure out, how to get better than a 7-8 year 50% success rate of atrial fibrillation. The duration and need for long-term anticoagulation, as we discussed before, still a bit of an open question and moving target. The potential for structural remodeling outside of that heart failure group. Why do some fail? What do we do with persistent atrial fibrillation? Dr. Voigt's going to talk more about this and options there, but I think it's still a fruitful area that we need to learn more about. And really, other than fire and ice, I think very important that we have really no good head-to-head comparisons. It's not necessarily in the manufacturer's interest to push those comparisons, and we need to do that. So I'm going to put a plug in here for our Center for Atrial Fibrillation, because I think that's where we can come in to see these patients early in their disease care as we're learning about these new technologies, and really try to impact stroke rates to make sure people are on guideline-directed medical therapy. There's data out there showing that newly diagnosed AF managed in a specialized center have improved outcomes, largely because of getting them on appropriate anticoagulation and stroke mitigation. All of our patients that come through the center get a specialized packet. I think the important point is this risk factor modification, so that the patients know why we're talking about these things and are engaged in, and until they're engaged in their own care, just like that Arrest AF trial, we're not going to make significant impacts on this. So, and we've made this a 24/7 consult service, always available for inpatient and outpatient referrals. So with that, I'll end and happy to take questions and discussion. Thank you all.
Thanks very much, Dr. Jain, for a really superb overview. Looking forward very much. A couple of questions have come in. One of them from David Morello. Is there a period of time that a patient has remained in AFib in which you no longer attempt the ablation? 1 year, 2 years, question mark?
Yeah, I think that's a great question. It comes up all the time. When we classify atrial fibrillation, if they're paroxysmal, but have had it for many years, I would still consider it, because they're showing us they have the ability to maintain sinus rhythm. What I think Dr. Morello is probably referring to is the persistent patient. So we divide patients between long-lasting and, if you will, short-lasting persistent, and 2 years is about the time where we start saying, maybe not. Now, Dr. Voigt may argue that in his next talk about, can we push that limit? And if they're having symptoms, I think you open it up. But for a catheter-based ablation, at about a couple of years, I start getting shy.
Another question is, are there any long-term data? That is, 10 years? We have 5-year data, but what about at 10 years? What do we know about ablation in that patient population?
Yeah, we do have data. Whatever it is probably on the order of 40 to 50%, 10 years of all comers. Having said that, if you take what we used to call lone atrial fibrillation, paroxysmal, structurally normal heart, maybe closer to 65, 70% at a decade. But absolutely a good point that we don't have a lot of data at that time duration.
Perhaps a final quick question and a quick answer is, what do you do with the young patient who have healthy hearts? Let's say you have a young patient coming in who's got paroxysmal AFib, and let me expand that a little bit because we're going to touch on this issue. Do you start with lifestyle modification? Does caffeine elimination, alcohol elimination, exercise, diet impact before you should go to the ablation? You showed us data that it does impact once you've been in. Do you start with lifestyle before going to ablation or drugs or strategy of rhythm control?
I think you have to. I think that, I spend probably more time nowadays talking about lifestyle and risk factor modification and making sure patients understand that that could have enough impact that they won't have to come to the table or the procedure, and then bring them back. And unfortunately, when it comes to obesity, I think we don't have great ways to make headway in that few months that we give them, and often are ending up with a procedure. The only other thing I'd mention about the young patient is we always have to think of SVT as a trigger for atrial fibrillation. So I think we have to look. And it used to be before AF ablation, the bar was so low, we would take those patients for a diagnostic EP study to make sure there wasn't an accessory pathway or a regular SVT that would end up being the source of their atrial fibrillation.
Yeah, excellent questions. There are a couple of them that have come up related to hybrid and convergent therapy, and that's a perfect segue. So Dr. Jain, thank you very much. Please stay up and